listen. What does it mean, listen? If you're on a bench watching a football game, you're focused on the mechanism of injury, that helps you a lot. If you're watching video from an injury, that helps you a lot. Sometimes the player tells you what happened. Okay? So let's start with the listen. What does it mean? A player comes in and says, I have an ankle sprain. The first thing you do is sit and say, exactly tell me what happened, how do you feel? Why do you have to do that? Because half of the time the mechanism of injury already tells you the diagnosis. For example, the player says, I was heading, I was taking the ball, I landed, was taken by a defender out of balance, and I twisted my ankle. Now, most of the time, that will be an inversion sprain. An inversion sprain means that you open on the lateral side and you close on the medial side. So you can have pain on the medial side, pain and swelling on the lateral side, but the mechanism of injury tells you already what it is and how bad it is. You don't even have to look or do more than that or feel. So a player who says, I jumped, I landed, I got stuck with my toes in the grass and I fell on my ankle like this, that's also called an ankle sprain. It has nothing to do with an inversion. That has to do with an eversion external rotation, most commonly in dorsiflexion. Now if you see that on the video or on the pitch, or the player is able to tell you that, you know the player has a syndesmotic injury. So just by listening, you have already a good idea. For example, a player who says, Doc, I was running really fast. I was going for that ball in a sprint with the defender and suddenly I felt like somebody hit me from behind and I couldn't walk anymore. What does he have? Achilles tendon. So just by listening, you know. Now, of course, we all have different backgrounds, different experiences, but the basics are the basics, and that's just the most important. And then you define how far you want to take it. But listen. For example, in history taking, it's so important to just listen and say, did you have previous sprains? Because just like with hamstrings, the most common reason to have an ankle sprain is to have a previous ankle sprain. You see? So just listen and say, do you have recurrent ankle sprains? Then probably it will be an inversion. Now, in my experience, it's very common that the players have no clue how it happened. They're on the pitch, they're very focused, they're full of adrenaline, and they say, yeah, I sprained, I don't really remember how it went. So this is a bit of a problem, but the new technology helps us a lot. Every training session, every game is now on TV. So I really forward the message, take your time, go back, look at what happened, because it will tell you already what it is most of the time and how bad it is. Okay? Having said that, we go to the two sorts of ankle instability. You have functional instability and mechanical instability. Now the functional one is where the athlete tells you, I sprain all the time. If I go down the stairs and I turn, I twist. That's functional instability. The mechanical instability is when you test it, and the testing shows a clear drawer sign. Now these two are very important, because if you have a combined mechanical and functional instability, you have a problem. And that's important to know. So far for the listening. Any comments on that? Anything you want to add to that?
Why do you say that the ankle is most commonly overlooked? You had mentioned it in the beginning.
Yes, what I mean is that we easily call an ankle sprain insignificant because they tend to heal fast with good functional rehab and tape. The problem is the congruency of the joint. If you have a knee that is affected by a ligament injury, the knee is not congruent and you will easily have instability clinically and you will deal with it. Nobody will say bad about you if you say you have an ACL injury, you need surgery. Now, if you have a syndesmotic injury or a lateral ligament injury, a very congruent joint, the ankle tolerates that for a few years because of its anatomical stability. But in a way, it's a similar injury, but just in a congruent joint. So over time, you will develop problems that are related to that obscure instability, but it's not that clear compared to knees or shoulders. So the point is, it's not because it's an ankle sprain, a lateral ligament sprain, or a syndesmotic sprain that it's insignificant. And that's what I mean by being overlooked.
Okay.
So it's a message out there to say this is more serious than we thought before, because we do see all the cartilage injuries, we do see malalignments collapsing, and we do see progressive instability in these patients. So that's in a nutshell about the listening. Listen carefully, and you know already the answer in most of the times. Then we come to the look. You have a player coming in, big swelling after a sprain. What's the first thing you do? Rise, rest, eyes, compression, elevation. Now that's standard. I advise you, and most of us do, to listen and to look, but not to go for any diagnostic tests at that stage. Why? Because it's not sensitive or specific. A big swollen ankle, it can be anything. So it's not bad, and it's even good treatment to tell your player, let's ice it, let's compress it, let's elevate it, and re-evaluate in 36 hours. Now it's hard to convince your player because they're going to ask for ultrasound, for X-ray, for MRI, but the best way to treat your player is to pull back and to say, okay, we will re-evaluate in due time, and meanwhile we will start the treatment that you need anyway, so you don't lose time. Having said that, you have to, in the initial assessment, do one thing only, and that is it bad or not. A big swollen ankle, whether it's medial or lateral, you have to know if it's bad or not. What do we have for that? We have emergency rules, which are called the Ottawa rules, where you can actually use them in an emergency setting to have an idea whether it's bad or not. You want me to show you the Ottawa rules?
Please.
Okay. I like to investigate an ankle sitting, but you can also do it lying down. It depends on your preference. So this is a non-injured ankle. Now there's 4 points of pain in the Ottawa rules. So if you have this acute ankle injury with your player, you should palpate 4 areas. 2 on the medial side and 2 on the lateral side. The first one on the medial side is the back side of the medial malleolus up to 6 centimeters. If you have specific apprehension in that area, you have to watch out that there's not an obscure fracture going on. Same thing on the navicular. You feel the soft spot of the ankle, and then you go a bit lower and you feel the soft spot of the talonavicular joint. If you go then to the navicular area and you push here, that might be an indicator of a fracture also. So, medial malleolus 6 centimeter up and medial here. Same thing here. You go to the lateral malleolus from the distal fibula tip all the way posteriorly to 6 centimeters. Why not anteriorly? Because that's where all the ligaments are sprained and you will not have a clear idea if it's bad or not. So you have to go posterior. Okay? And the second one is of course at the base of the metatarsal fibula. So 2 here and 2 here. Another rule in the Ottawa rule is that you have to be able to make 4 steps without big problems. So we didn't even really touch clinically with testing, and we have already a very good idea on what it is and how bad it is. And so ankles, you can really deal with it in a clinical, history-taking way, and that helps you a lot furthermore. Now, an MCL runs like this. You go in valgus and you tear it, you pull it up. Simple logic. Now, how is the course of the ATFL? It's from the front side of the distal fibula towards the talus. If you do inversion, it doesn't make any sense, right? Why would it be the most commonly injured? It's not like an MCL that you go in valgus and you go in inversion and you have a ligament that goes like this. Why would that be the most commonly injured? Come on, guys. It's simple, eh?
Dorsal.
Yeah, because most of the time the problem goes in plantar flexion and inversion. So always think about the mechanism, because the moment you go in plantar flexion, your ATFL becomes an MCL. You see what I mean? I mean an LCL anyway. Eh? So you have to think about the ligament position and about the ankle in a very dynamic way. And that will help you in the process of learning more about it. Anything else? So, look, have a good idea. The player comes in, you didn't even touch, you did your Ottawa rules, but you look. You say, where is the swelling? Is the swelling lateral? Probably inversion to it. Is there a hematoma somewhere? Of course, if it's only lateral, the hematoma will develop, but sometimes you have medial hematoma. Now, if you have a medial hematoma, you have two possibilities. Many, but two frequent ones. You have a lateral ligament sprain that went in inversion and afterwards in eversion. People who land on another's foot can have that. Click, clack. Now, if you have a hematoma medially, that has to be a signal for you to say, oh, this might be something. Another sign of a medial hematoma is, for example, a syndesmotic sprain. You have a big pain and effusion here, and you have a medial hematoma. Then you think, that's probably not an ankle sprain inversion. That must be something else. So then you go further and you say, do you have any radiation up? Do you have any mesial nerve? Any proximal fibular pain? So just by looking, hematoma here, for example, you already have a whole set of ideas thinking this is probably not inversion. This is going to be maybe syndesmosis or inversion, eversion, or fracture, of course. So all things to consider. A big swelling on the outside can be metatarsal 5, can be ATF LCF, can be flexor retinaculum. All things to consider. So we didn't even hardly touch the patient, and we already have a whole setup of ideas where we take all the signs and we puzzle it towards one ultimate diagnosis. That's okay? So we listened and we looked. And then, of course, we start our diagnostic setup with clinical examination. Now you have predominantly 5 topics related to ankle sprain. You have cartilage, you have impingement, you have tendon pathology, what else? You have fractures, and you have instability. So these 5. Now maybe we start with instability. That's the most common one. Okay? What are the 2 tests that after your 36 hours of RICE that you would want to do to know if there's a lateral ligament injury? It's the anterior drawer and the talar test. Yeah. So why don't we do the anterior drawer test? Now you can do it lying, you can do it sitting. I'm just going to show how I do it, but there's many other possibilities. Now the best way to check an instability in testing is to just do a proper drawer. Now how do I do it, or how do many in Europe do it? You can just stabilize the distal tibia. You put the ankle a little bit in neutral position, okay? Because in plantar they always move, but in neutral position, not dorsiflexion, but neutral position, and you take the heel. I personally take the heel like this. Many people take it like this. It doesn't matter, as long as you have your personal preference and appreciation of instability. Okay, so what do? We try to use the heel as a fulcrum to bring up, okay? What do? We stabilize with the left hand, we take the right hand and we do an anterior draw. Okay? That's how we do an anterior draw.